is Deep Check Medical Services, Vinita? Where is
It's
which
look
city?
it's located in Pune. They're Pune
In
based.
Pune.
Yeah,
Right, right.
I work online for them, so I do the teleradiology for them. I
Oh,
read
I see. Okay.
MSK and spine MRIs for
Sure,
deep tech.
sure, sure. So you're
So
based
most
in India?
I'm based in Gurgaon now. Yeah.
Oh,
So
okay, sure.
I lived in the Philippines 22 years, but we have come back.
Yeah, I thought there is a lot of Philippines in
Yes.
your profile. But Gurgaon is excellent because we go to India often. Maybe we'll catch up face to in
Oh
person
yeah,
sometime.
that would be lovely. Just let
But
me know.
yeah,
I'm
no,
also very close to the airport. I can come and get you.
yeah, good. Glad I asked you where are you.
Yeah, except that it's too hot at this time, too
It's
warm.
okay. Yeah, I think I'm a type of person I like heat rather than cold.
And it's winter for you at this time.
It is absolutely. It is starting to get freezing cold now.
Okay. So I think we can try to, I don't know.
We start?
Yeah, I think so. We can start. I think people will still join in.
Yeah, sure.
Yeah.
Okay. Yeah, sure. So, hello and welcome everyone. My name is Anju Agarwal, and I'm a family physician in Sydney, Australia. Today is we will be talking about a very, very important and challenging topic, multiple myeloma by Dr. Sanjay Gandhi. And it is moderated by Dr. Vinita Sharan. A brief intro about Dr. Vinita Sharan. I think we have worked together so many times, I
Yeah.
almost know her very well now. Um, Dr. Vinita Sharan is a senior radiology consultant at Deep Check Medical Services. Dr. Vinita is also adjunct faculty of Public Health Foundation of India. Dr. Vinita is former associate professor, San Beda College of Medicine, Philippines. She is advisor of radiology CMEs of GAPIO and very instrumental in organizing the virtual radiology sessions for GAPIO. And this is her 11th session under her mentorship, and that's amazing. Very warm welcome, Dr. Vinita, and a big round of applause for you. Thank
Yeah.
you.
Yeah. Thank you, Dr. Anju, for the opening remarks and also for the kind introduction. Yeah, indeed, it's been very nice working with you. And thank you so much for your continued support to our Radiology International Lecture Series, even though it gets too late in Australia for you.
My pleasure.
Yeah. And greetings, everyone, wherever you are. Greetings of the day to you. Welcome to the Radiology International Lecture Series organized by Global Association of Physicians of Indian Origin. Before I start, may I request the audience to place their questions in the chat box below. We will have a 10 minutes question and answer session at the end of the talk by Professor Gandhi. So, multiple myeloma. This is a very important topic, and this talk or this session is going to be very interesting because our speaker, Professor Sanjay Gandhi, would be talking about advancements in imaging and management of multiple myeloma. Multiple myeloma, it accounts for around 1% of all malignancies and 10 to 15% of all hematological malignancies. Role of radiology is multifold. Firstly, in diagnosing, then in detecting any complications, and also in monitoring response to treatment. So starting from X-rays, and we have come a long way, and now we have multiple arsenals in our armamentarium to continue and do all these roles very successfully. So I will stop at this and I will introduce our chairperson for the evening today, Dr. Amita Malik. Dr. Amita Malik is the professor and head of department of radiodiagnosis at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. She has about 52 publications in national and international journals, and she has contributed one book chapter, Radiology in Intensive Care Unit, and she has also edited a book, Dannert Book of Radiology Review Manual 2020. And she has been awarded President Appreciation Award 2020 from Delhi State Branch of IRIA. I now would like to invite you, Dr. Malik, to introduce our speaker, Professor Gandhi.
Thank you, Dr. Vidita, for the kind introduction. It's indeed a pleasure to be part of this event. And as has already been told, that multiple myeloma is a very important malignancy occurring in adults. And what is important is that with advancements in imaging, it is now possible to detect the disease early or to identify patients who are at high risk of developing the disease, so that interventions at this stage are very helpful in determining the prognosis of the patient. And it is my pleasure to have with us Professor Sanjay Gandhi, who would be speaking on the advancements in imaging and radiological management of multiple myeloma. Professor Sanjay Gandhi is Research and Innovation Lead for Core Clinical Service at North Bristol NHS Trust and Lead for Radiology and Diagnostic Imaging at University of Bristol. In his 35 years of career span, which has included 3 postgraduate radiology degrees from UK and abroad and a body imaging fellowship from USA, he has won several awards for his contribution to healthcare innovations and higher education. He has published more than 60 research papers in reputed international journals, and he has many awards to his credit, which include Times TV Network honored him as Global Academic Icon and British Medical Association as a highly commended editor. Professor Gandhi has contributed greatly to higher education, and he has developed the iPhone app also, and he has led his contribution is immense in the development of UK's national imaging guidelines. He has co-authored or edited 11 award-winning textbooks. Over to you, Professor Sanjay Gandhi.
Thank you very much for kind introduction, and thanks Gapio for invitation to share my expertise in myeloma imaging. I've been lead radiologist for over 2 decades, and today I'll share some of that experience with you. I work at North Bristol NHS Trust. This is outside view. And what you are seeing as my background is inside of the hospital. I've got various educational roles, but there is no conflict of interest, so I have no declaration with respect to today's lecture. In addition to doing radiology, I have interest in publishing books and creating apps and other healthcare technology, including AI. So today, what we'll discuss is myeloma spectrum and its different subtypes, role of radiology, different imaging techniques from diagnostic to interventional, and their advantages and limitations. We'll look at International Myeloma Working Group recommendations and other latest developments. At the end, there will be question and answer session. So multiple myeloma is characterized by a proliferation of monoclonal malignant plasma cells. The disease starts in the bone marrow and it eventually spreads into the peripheral blood or can expand into the soft tissues. Plasmacytoma, on the other hand, is a solitary plasma cell tumor, and it presents as a mass but does not have systemic spread. There is another variety called extraosseous soft tissue myeloma, which primarily, as the name suggests, arises outside the bone and generally associated with poor prognosis. MGUS, which is monoclonal gammopathy of uncertain significance, it must be differentiated from multiple myeloma because it's asymptomatic and patient have abnormal blood tests, but they don't have symptoms. It is fairly common, and 3 to 4% of population over the age of 50 can have MGUS. The rate of progression of MGUS to multiple myeloma is 0.5 to 1% per year. Then we have smoldering multiple myeloma, which is early stage or asymptomatic disease. And it also carries risk of progression to malignant form. And within first 5 years, it is about 10% per year. There comes a variety called non-secretory myeloma, which is a challenge for our clinical colleagues because it is not secreting abnormal M protein. So it is difficult to monitor by lab tests. So imaging has a significant role in management of non-secretory type of multiple myeloma. There are different symptoms patient can present with, which include bone pain, especially in the spine or chest, fatigue, weakness, frequent infections because marrow is being replaced by plasma cells. Patient can have anemia for same reasons. They are not producing enough RBCs, weight loss, renal impairment, and hypercalcemia symptoms, which can include nausea, vomiting, confusion, as well as constipation. So how can we diagnose multiple myeloma? We need a certain tests which include measuring calcium, kidney function, blood counts, as well as M protein, and urine analysis to detect Benz-Jones proteins, and imaging tests which can include X-ray, MRI, or CT scan, which we'll discuss in detail, and patient often needs bone marrow biopsy to detect abnormal plasma cells. So role of imaging is to verify the extent of skeletal and, if any, extraskeletal involvement, provide information necessary for accurate staging. There are different staging systems, but most common is Dury and Salmon Plus, and assess stability of involved bones, preempt any fractures and impending spinal cord compression due to myeloma deposits. Imaging is also used to monitor treatment response and look for any complications of therapy or early prognosis. So we should be able to tell our clinical colleagues whether patient has got MGUS, smoldering disease, or frank florid multiple myeloma. We should be able to differentiate plasmacytoma from multiple myeloma. And if patient presented with lytic bone lesions on as an incidental finding on X-ray, to differentiate multiple myeloma from other bone lesions, for example, metastasis. So imaging can be broadly divided into two categories. One is morphologic imaging, which looks at the effect of tumor, for example, bone lysis on plain film or CT scan, and tumor deposits on MR or ultrasound, which is good for soft tissue lesions as well as obtaining biopsy. And we have got another big category called functional imaging. Morphological imaging looks at the effect of tumor, whereas functional imaging looks at the tumor itself and its malignant potential. So in that category, we have dynamic contrast enhanced MRI, diffusion weighted whole body MRI imaging, and PET scans. PET now is being used in combination with CT or MRI. So let's look at each of these together. So in morphological imaging, we have plain X-rays, which have been with us since 1895, plain films, and these were used for screening of skeleton and were um, standard of care for many decades. The hallmark is neoplastic bone leading to osteoporosis or focal bone destruction. There are several advantages of plain films. X-ray equipment is widely available even in developing countries. There are no waiting lists, and it's an established low-cost procedure. Traditionally, we perform on average 9 radiographs, which include skull, whole of the spine, chest, pelvis, and long bones, because myeloma deposits have tendency to involve axial as well as peripheral skeleton. And on a typical radiograph, a myeloma deposit would be a punched out lesion. And as the name suggests, these are often multiple. So what we have is a what is called pepper pot skull because of multiple lucent destructive bony lesions. And traditionally, the teaching is if you start to see lesions within the mandible, they are more likely to be due to multiple myeloma rather than metastasis. However, plain X-rays have significant number of limitations. They have low specificity compared to advanced imaging modalities like CT and MRI. It is said that around 20% of myeloma patients have no abnormal findings on plain X-ray, and it cannot be distinguished osteopenia or vertebral collapse caused by myeloma from more common causes such as osteoporosis or bone thinning due to corticosteroid use. Mind you, this disease occurs in elderly, so osteopenia is very common in that age group. So X-rays have their limitation. Plain films rarely show or grossly underestimate soft tissue component of myeloma, and at least 30% of bone loss is required for any lesion to be visible on plain X-ray. There is another problem with plain X-ray is superimposition of structures which make assessment of bones even more difficult. Superimposition occurs mainly in the region of face where front of face overlaps the back, or in the chest where sternum overlaps the spine, or in pelvis. There is another limitation of plain X-rays. They have low specificity. Here I show 3 radiographs of pathological fracture involving right humerus. One of these cases is lymphoma, other is myeloma, and third one is metastasis. And on plain film, it is not sensitive, very difficult to say which one is multiple myeloma. Most of my registrars pick this one because it looks like more of a myeloma deposit punched out lesion. But in fact, this is lymphoma, this is myeloma, and this turned out to be metastasis from renal cell carcinoma. So the sensitivity of plain film is less compared to other techniques like MRI and PET scan. We were talking about superimposition. This patient was referred by GP for sternal pain and mass. Nothing was visible on chest X-ray, so we did an ultrasound. This is front of sternum, and there was this soft tissue mass. There was some soft tissue mass at the back, but its extent was obscured due to presence of bone, which stops the sound waves from getting into the assessment into mediastinum. On color Doppler, there was pathological vascularity. CT of same patient shows bone expansion and replacement of normal marrow with this soft tissue mass. There is anterior extension which GP was able to palpate, but CT beautifully shows extension into the anterior mediastinum, which was not very well picked up by ultrasound. And this is chest X-ray of the same patient. You can say chest X-ray, anyone would report normal because none of these were visible on chest film. So there are advantages of a CT scan. Number one is there is no problem of superimposition. It's a 3D imaging technique. Whole body CT is superior to plain films for finding focal bone destruction. And these days, low dose whole body CT radiation is almost same as radiation one would get from whole body skeletal survey. So, and other thing is it is disease of elderly. It's not in reproductive age group, so radiation is not an issue, but we uh, are nowadays using low dose unenhanced CT, which is very safe procedure. And CT can demonstrate extraosseous soft tissue myeloma. Having done hematology cancer meeting for 20 years, I've seen myeloma involving almost any body part. This is known case of myeloma, which over the years developed this plural myeloma deposits. On plain X-ray, we would only pick up pleural effusion, but would not be able to comment on soft tissue component. Another case, we have presence of this intraorbital soft tissue mass along the lateral wall of right orbit. Plain X-ray would have no chance of picking such soft tissue abnormality. There are certain limitations of CT scan also, like X-ray films. CT only shows damage to mineralized bone. It does not pick up diffuse bone marrow involvement within the preserved spongious bone. So we come to MRI, which is more sensitive method for detecting focal multiple myeloma as well as diffuse marrow infiltration. This is a lumbar spine radiograph. I was able to pick up subtle bone destruction here because this is normal posterior part of the vertebral body. That's how it should look. But you can see here there is some bone destruction going on. When we did MRI, we were able to see this soft tissue replacement of normal marrow. And this was encroaching into the spinal canal. Fortunately, there was no compression of chorda equina because we have preserved CSF space. But what is also obvious is diffusely low signal marrow throughout. In elderly patient, the marrow within these vertebral bodies should be of fat density. You can compare it with either subcutaneous fat or presence of fat within the pelvis. So see how dark this is compared to the fat signal. So not only we had this focal deposit, we also had diffuse marrow involvement. Commonly used MRI sequences are T1 weighted spin echo sequence, T2 weighted images with fat suppression, and star images. So normal marrow fat would look very similar to the fat signal elsewhere in the body. Then you have focal deposits, as you can see here. A deposit here is deposit there, smaller one up there. And this is a case of diffuse marrow infiltration. You see, that's how it should look like or you can compare this one with that one. So there is diffuse low signal in the vertebral bodies. On star images, myeloma deposits will look bright. So we have got focal deposits in the upper thoracic vertebrae as well as spinous process. So these are star images. MR has advantage of differentiating osteoporotic fractures from multiple myeloma deposits. Plain X-ray and CT, it is difficult to say whether fracture is due to osteoporosis. In these cases, we have got normal fat signal from vertebral bodies, which is fairly similar to the signal in subcutaneous fat, whereas this pathological fracture marrow has been replaced by myeloma deposits. Same can be said about these vertebrae. So these fractures are pathological in right clinical setting with abnormal blood tests and abnormal urine tests. These would be in keeping with myeloma deposits. There are certain limitations of conventional MRI. One is acquisition time is prolonged. Depending on what type of scanner and software you use, it can be 30 to 45 minutes. It has high cost compared to X-ray and CT scan. In addition, conventional MRI is not reliable for skull, clavicle, and ribs because of false negative results. Ribs mainly because amount of marrow there is limited, as well as motion artifacts, because MR techniques take long, and MR specificity is also relatively limited for conventional MR. Again, it shows tumor but not its activity or viability. So all morphological imaging modalities have this limitation when it comes to assessing treatment response or early progression. Then we come to functional imaging, and this is a game changer. It provides radiological as well as pathological correlation. Several imaging methods are available to measure microcirculation of tumor tissue, diffusion of interstitial water molecules for diffusion weighted MRI, or pathological glucose uptake as a marker of tumor viability and aggressiveness. That helps in imaging of these tumors by PET scan. About 15 years ago, we had a lot of enthusiasm in dynamic contrast enhanced CT, which transpired a lot of studies in diffusion contrast enhancement MRI also. But over the years, that enthusiasm died out. Main reason for that is dynamic contrast enhanced MRI takes even longer to acquire images. A routine MR would take 30 to 45 minutes, but when you give IV contrast, you have to obtain coronal, sagittal, and axial images after contrast also. So these patients are often elderly, some have back pain, so they find it very difficult to lie on table for hour or more. Moreover, myeloma patients are already at high risk of renal impairment. Therefore, there are increased chances of contrast-induced nephrotoxicity. So that's why people did not take up on diagnostic contrast-enhanced MRI. Moreover, better imaging modalities came along, and game changer amongst these is diffusion-weighted imaging, commonly known as DWI. It is based upon measuring the random Brownian motion of water molecules. Normally, water molecules will move freely between normal cells, but malignant tumors with densely cellular tissue and more cellular membranes per volume unit impede the mobility of water molecules and restrict their diffusion. So diffusion is impaired within the tumors, and DWI also serves as a tool to monitor treatment response and look for any progression. 4 years ago, I was involved with the multi-center trial of implementing whole body MRI along with Royal Marsden Cancer Hospital in London. We implemented imaging protocols along 10 other hospitals, irrespective of whichever make of scanner you have, whether it's Siemens, Philips, or GE, or any other make. We were able to set up these protocols so that if patient is transferred from one hospital to another, we'll have standardized imaging protocols. And this article is available as open access, so you can download for free. I'll put up the reference to this article and any other reference I use in the chat box once we finish this talk. So there are certain terminologies which are used for diffusion weighted images. One is whole body diffusion weighted MRI. Then you would come across ADC, which is apparent diffusion coefficient, which is a measure of magnitude of diffusion of water molecules within the tissue. And then comes diffusion weighted whole body imaging with background body signal suppression, which is helpful in picking smaller lesions. So this image is from our paper. You would end up by using these imaging protocols. This is inverted grayscale with maximum intensity projection, which gives us images very similar to what we are used to when we use nuclear medicine scans, and that can pick up the show up the lesions as inverted grayscale. You have diffusion weighted images, ADC, which is automatically calculated by the software to generate ADC images. Then T1 weighted images, which is fat sat and fat only or water only. In the coronal plane, you can see where the images had been joined together. This is also called stitching of images. Software automatically does that depending on patient's position in the scanner, so that you get whole body images, and you also review these images in the axial plane. In the past, we used to use head coil and overlap body coils over each other, and software did the stitching. A lot of manufacturers now come up with dedicated coils for whole body MRI, and you don't have to do overlap of different coils, and it is far easy to use. Different manufacturers have different names. This image is courtesy of Philips. So if you are planning whole body MRI for multiple myeloma, you should do the coverage from vertex to knees, and I'll show the reason why we should cover up to the level of knees. Whereas if you are doing whole body MR for cancers or lymphoma, then vertex to mid thigh is fine. You don't need to necessarily go down to knees. There are different sequences for MRI, and that's a lecture of 45 minutes in itself, but it is broadly based on this article, and I will share the references with you for anyone who is interested in reading a bit more about these. But in summary of that article, we use T1 weighted gradient echo technique to produce in and out phase images to allow calculation of fat only and water only images. These T1 weighted images are useful in detection as well as characterization of lesions. These also tell us if patient is responding to treatment or not. Sorry. Then we have T2 weighted images, which are used for evaluation of disease in organs other than bones. for example, extraosseous myeloma. We add sagittal T1 weighted turbospan echoes as well as stir images for whole spine. These are useful for detection of vertebral metastasis, fracture, and spinal cord compression. We have seen some examples previously of vertebral fractures and encroachment into spinal canal. So DWI are added to these image sequences to detect malignant lesions due to their high cellularity. And on a typical DWI, we see lesions which shine up as bright as a light bulb. So there are multiple deposits in this sacrum and both hip bones. We can see deposits in the spine. And for any trainees who have joined this talk, you should be able to see the lesions which are as bright as spleen in a female patient. In males, if suppose you only had pelvic scan, these would be as bright as testis because testis and spleen are very bright on diffusion weighted images. So these are typical myeloma deposits. Another example, we have got deposits in the right humerus, iliac bone, incidental gallstones, by the way, and we have deposits going back up to the distal end of right femur. As you can see here, that's why we need to include both humeri as well as femur in our imaging field when we are looking at myeloma, whereas metastases generally do not go that far, or they go, but they are relatively less common. And we talked about inverted grayscale images, and just looking at single image gives you a good idea how much is disease burden in this patient. These are all myeloma deposits. Now let's look at the role of nuclear medicine. Traditional bone scan, which we do with technetium 99M, does not pick up myeloma deposits because these are osteolytic rather than osteoblastic ones. Technetium is good for osteoblastic activity, for example, prostate or breast cancer, but myeloma deposits do not show up. Main role for bone scan is to differentiate lytic lesions seen on X-ray and differentiate them from metastasis to fractures or pick up fractures. But PET, which also comes under nuclear medicine, is very useful. We use a tracer called FDG, which detects tumor due to high glucose demand because these cells are rapidly dividing, so they need lot of glucose. And when glucose is labeled with this radioactive tracer FDG, we can pick up which areas are taking lot of glucose. And nowadays, PET scan is used along with fused images of either CT or MRI. So you have got PET CT or PET MR. CT and MR give anatomical detail, whereas PET gives us functional imaging. So on PET, solid myeloma nodules have increased uptake of FDG, but their conspicuousness depend on uptake of the surrounding tissue as well. So any lesion around the heart, because myocardium takes lot of FDG, it becomes difficult. Same is true. Brain is very avid user of glucose. So lesions around these organs are relatively challenging to pick up. And diffuse marrow infiltration has a rather low metabolic activity and therefore relatively difficult to detect by PET scan. Let's see a few examples. Plain X-ray was relatively unremarkable on this patient, whereas when PET scan was performed, you can see a lot of FDG activity inside this bone, and CT was able to show bone dissection. So a lytic lesion with lot of FDG activity and that's L3 vertebra. And on L4, we have got another lytic lesion involving the left half extending into the pedicle. See, plain X-ray did not detect any of those lesions. So these were all FDG positive. Another case, it is interesting. This was initially thought to be a myeloma deposit because patient had abnormal blood tests and benzone protein in the urine. But when patient had PET scan, this lesion did not take up any FDG. This was just an incidental benign lesion, whereas L5 vertebra showed up increased uptake as well as lot of activity in the spinous process. So PET scan can pick up lesions which conventional CT cannot pick up. And after chemotherapy, there should be a drop in FDG uptake, so it can be used um, to monitor response to treatment. For PET scan, we use standardized uptake value SUV. So if SUV was initially say 100 and it drops below um, that value, then we know tumor is responding. Ideally, they should go below the level of mediastinal activity or liver activity. That is considered as complete response for that lesion. There are certain limitations of PET-CT. Skull and rib lesions are again more difficult to detect on PET. In up to 30% of cases, positive on MRI, PET can be false negative, and that happens usually with diffuse infiltrative pattern. So MRI, especially diffusion MRI, is very helpful when you're suspecting diffuse marrow infiltration. And PET is not as widely available as other imaging modalities, and it is very costly for two reasons. PET scanners are costly, and you have to produce a radio tracer which has very limited shelf life. So you need cyclotron to produce FDG. So for all those reasons, PET has limited availability in many parts of the world. So let's look at treatment options. It can be chemotherapy, immunotherapy, stem cell transplant, radiotherapy, supportive care. It all depends on stage of the disease and patient's health. And treatment response we already discussed on PET scan. MRI is also very useful. This is pre-treatment, fatty marrow being replaced by this intermediate signal deposit. And after treatment, there is fat replacement and the tumor has shrunk. On stir and diffusion weighted images, deposits are bright and this was a large lesion, and after treatment, its size has reduced. International Myeloma Working Group created some guidelines for diagnosis of multiple myeloma, and anyone interested in this is also free to download. I'll summarize their findings. Whole body MRI is beneficial in evaluating patients with smoldering myeloma and is recommended as part of initial assessment. Abnormal MR imaging findings in smoldering myeloma include both focal and diffuse bone marrow abnormality. If whole body MRI is not available at your institute and regular MRI is available, then you should try to do spine and pelvis because these areas are difficult to assess on other imaging modalities. Presence of more than one focal lesion was associated with substantial risk of progression, and diffuse marrow infiltration is associated with increased risk of progression as well. When you have very small lesions which are less than 5 millimeter, then you can follow these up with CT or PET scan, whichever is available. There are different staging populations. I'm aware of time, so I wouldn't go into too much detail. This is applicable to those who regularly are present at uh, myeloma cancer MDT, and you can look these up online, freely available. Let's look at other role of imaging. It is helpful in picking up the complications of treatment, which include chemotherapy or osteonecrosis from bisphosphonate or complication of radiotherapy. Radiotherapy can make bones osteopenic, so they can be secondary fractures. So this is a case of osteonecrosis, which is a painful condition which can occur when patients are given bisphosphonate to strengthen their bones. Uh, let's look at role of interventional radiology. Interventional radiology is very useful in obtaining the biopsy from bone lesions. And we can do vertebroplasty or kyphoplasty through a wide bore needle. We can inject cement to strengthen weakened bones to reduce the risk of further fracture and reduce pain. We can burn the tumor with heat. Previously, people tried cryoablation. Cryoablation worked very well for small renal tumors, but it is not that useful for myeloma. But then we would also look at new tracer cinema. Coming to radiofrequency ablation, we use high frequency alternating current to burn tumor cells. This is a typical setup. A needle is inserted into the lesion, and with heat we kill the bone cells, abnormal cancer cells. Ideally it should be near the center, and you can obtain biopsies. Biopsy has not been previously taken, so it's triple stage procedure. Take the biopsy, do the radiofrequency, burn the cells, and put the cement and strengthen the bone to reduce future risk of fracture. A lot of different tracers have been tried. They have been successful for prostate cancer, but we are still trying to find a good tracer for multiple myeloma, and at present our uh, experience is very limited. Just to recap, in multiple myeloma, role of imaging is to determine the stage of the disease and to anticipate complications such as fracture or cord compression. Cross-sectional imaging is replacing plain films. CT has certain advantage, and MRI is really a game changer, particularly diffusion-weighted MRI. And it is more sensitive than CT and PET for diffuse marrow infiltration. International Myeloma Working Group recommends that either CT, low body, whole, low dose whole body CT or MRI of whole body should be considered in patients suspected of smoldering myeloma. If you don't have whole body MRI, then do the spine and pelvis. Exact imaging modality is determined by the availability and your local resources. And these are the references. I'll put these up in the chat box. The two good ones are the ones where this is to set up a whole body MRI service in your department. These days, the MRI people will set it up for you. You have got their application specialists. Otherwise, you can tailor it to your needs, and all that is covered in this article. Raj Kumar from Mayo Clinic has published a good paper on which is very comprehensive about diagnosis and management of myeloma, and this is the reference to the paper we published recently. And thank you for listening. We'll take the questions, and if we run out of time, you can reach me on Twitter and message me either on Twitter or via LinkedIn. Happy to take your questions.
Thank you, Professor Sajay Gandhi, for such elaborate presentation on multiple myeloma and how the things have changed and what is the future. Now, I think we can take up some questions if there are.
I don't see any questions being put up in the chat box, but may I ask one question myself?
Sure.
So Those centers that have both PET-CT and also MRI, whole body MRI facility, what would you suggest? Which one to do? Which will have a better
Yeah.
findings?
So my preference, if we have got both, one, it depends on the patient as well. MR would take long if they can tolerate MRI. My first preference would be diffusion weighted MRI because that is very good for diffuse marrow infiltration. And occasionally we come up with cases where diffusion weighted, it is still questionable whether it's myeloma or not. Then we restore to PET MRI, PET CT.
Okay, thank you.
Diffusion weighted MRI is cheaper also, and it has advantage of picking up diffuse disease, which PET CT struggles with.
And also no contrast is needed or dye is.
No contrast is needed.
Yeah.
No.
Okay, thank you.
And Professor Gandhi, I just want to know, like, what would you prefer? You said that skull lesions, they are difficult to pick up on MRI, and radiographs have low sensitivity.
Yeah.
So what would you suggest? Like, we would have to do, yeah.
For conventional MR, they used to struggle with skull, rib, and often clavicle, but diffusion weighted MR will pick these up.
Okay.
Because these they show up like light bulbs, so
Yeah.
because of the technique we use, they are very easy to pick up.
Thank you.
Professor Gandhi, that was excellent talk. I understand MRI might be the best way, but it is very expensive. Is there a cost-effective way to diagnose?
So traditionally, as I mentioned, International Myeloma Group also recognized that we are talking about best case scenario to use CT, whole body CT, or whole body MRI, or diffusion weighted MRI, or PET scan. But if suppose we are stretched for resources, which occurs, say, in parts of Africa and subcontinent, then you can restore to skeletal survey and complemented with blood tests for M proteins. So it's combination of those two, and patient may have Trifine as well, which is also not very expensive compared to the cost of MRI or a PET scan. So restore to the methods which we used about 15 to 20 years ago, skeletal survey, and complement it with other tests, blood tests.
In the skeletal survey, they mainly do this, the head, the scalp, and
yeah. So we do nine X-rays. So skull, cervical spine, thoracic spine, lumbar spine, laterals. We do chest, we do pelvis, we do both humeri as well as both femora up to the level of knees.
Thank you.
I have another question. I mean, in these days when you have corporate hospitals and PET-CT as well as diffusion-weighted MRIs, whole body MRIs are done, do you in your practice find discordant reports, like there was finding in one, not in the other? And in a situation like that, which one would you take as the better report or more sensitive report?
Yes, it depends case by case. I have quite significant confidence on the diffusion weighted images. And when it is focal disease, along with presence of bone destruction on PET, then PET is very good. So in addition to increased uptake of FDG, you should have some cortical destruction, as the case we saw earlier, where plain X-ray was normal, but when we did CT, CT showed lytic areas in two vertebral bodies, and there was corresponding increase in FDG uptake. So,
I think we do have one question. So there's a question. So would you advocate 9 X-rays as just first step in the first diagnosis?
So if you are suspecting, hi Anjali, if you are suspecting multiple myeloma, which suspicion comes on abnormal blood test or presence of benzone protein in the urine and patient is symptomatic, then if you have to do full skeletal survey. In our hospital, we have got rid of skeletal surveys because to position a patient, a skeletal survey used to take one room, radiography room, for nearly an hour in these elderly patients. They had comorbidity, details, and their mobility was limited. So we used to do 9 X-rays because we don't know where the myeloma lesions are going to be. So you have to do a full body skeletal survey. Nowadays we do low dose CT, and patient is actually on the table for less than 5 minutes. The preparation and everything is all set up, and actual scanning is within a few seconds. So patient find it more comfortable, and we pick up far more lesions on low dose CT as well as extraskeletal lesions, for example, in pleura, in orbit, which we won't be able to pick up on skeletal survey. So if you have got a CT available, that would be the investigation of choice compared to skeletal survey.
There is one more question. Seen Win. In already diagnosed case by bone marrow, metabolic assay, and M protein, can skeletal survey be used as staging?
Answer is same. Skeletal survey, you can miss up to 30% of 20% of cases. So if you have resources available, go for CT, which is fairly um, relatively cheap compared to MRI. If it is not available, then you use what you use. So you will be using what is available. But if you have both available and patient can afford or health insurance company will pay, then go for cross-sectional imaging. We have seen several examples in this talk. You won't be able to pick up lesions on front of sternum. We saw the case of sternum. We saw the case of intraorbital uh, myeloma. We saw the case of pleural multiple myeloma. I've seen myeloma affecting iris. Those won't be visible on an X-ray. Iris is not visible on an X-ray, as we all know. So yes, if you have nothing else available and everything else is pointing, a skeletal survey will tell you something. They can tell which bones are at risk of fracture. But if you are ready, then be prepared for lower sensitivity compared to other imaging modalities. And as I mentioned earlier, if you have any question later on, find me on Twitter or LinkedIn. Happy to answer any questions.
Yeah, I think there is another question here. Can you explore some treatment options at your hospital, and may I know success rate of treatment?
I would not like to dwell into that area because I'm a radiologist. That is for hematology oncologists. And also, put this question to Google Gemini. You will get a beautiful answer, better than my answer. I'm a diagnostic radiologist. I don't treat patients, fortunately.
We have another question from Dr. Ramani. What modality for follow-up? If so, what is the periodicity of follow-up?
Okay. So follow-up depends on many things. How your patient is responding, if their symptoms are getting better, if they are not as much fatigued as they were before, their bone pain is improving, and how lab tests are progressing, because all these imaging modalities what we use are costly, whether CT, MR or PET scan. So you have to assess them clinically. If there was a mass, for example, extraosseous as it reduced. When disease is in area which is not clinically apparent, then the best imaging modality is MRI. We saw examples because tumor response can be picked up both on T1 as well as stir and diffusion weighted images. So you can see reduction in the um, size of lesions as well as their brightness on diffusion scans. So MR is my choice of modality because remineralization on CT and plain X-ray can take some time, whereas MR is fairly sensitive and very good at picking these things up. You can use PET also, but PET again is very costly, so we try to not use PET for follow-up. But if it is readily available, there's no harm in using PET. PET can show tumor response. Often we see these patients have more than one cancer, so they get PET scan for another cancer, then you can compare the other ones. But otherwise, MR is the modality of choice for assessment of tumor response. And periodicity again depends on a number of factors that also depend on your disease response and lab tests, but there's no point in very frequent follow-up, and don't recommend following these more frequently than 6 months. So 6 months to a year, probably if necessary. So there is no fixed period for follow-up, whereas other cancers like lymphoma, they have got their follow-up, which is very standard. Again, follow-up for colorectal is very standardized, but for myeloma, there are no set uh, protocols for that you have to regularly follow these up. That is not necessary.
Thank you, Professor Gandhi. It has been a fantastic session and followed by question and answers. Dr. Vinita.
Yeah. Thank you so much. I think we were waiting for Dr. Sushil Jain. He's our honorary secretary, but he is unfortunately on another call. So I will probably give the closing remarks. And firstly, I would like to thank Dr. Anju Agarwal for staying up so late to be with us. And she has been a constant support to our Radiology International Lecture Series. Thank you so much, Dr. Agarwal. Then Dr. Amita Malik, thank you so much for being the chairperson for this evening, ma'am. It has been a nice addition to
My
our
pleasure. My pleasure. Yeah.
nice addition to our Radiology International Lecture Series, and your contribution has been great. And Professor Sanjay Gandhi, your talk was very, very clear and very informative. Especially, I think those who are not really doing this multiple myeloma cases every day for them, I think you did a very good job of starting from the beginning to the end. So very informative, very nice, and very interesting lecture by you. Thank you so much.
No, thank you, all of you. I think I enjoyed it, and there were a lot of participants. So thank you, Dr. Anju, Dr. Vinita, and Dr. Amita. I'm pretty sure we'll do more of these in future. And thank you to all the participants who joined on a Saturday. So wherever you are and whichever time zone you have, I wish you the very best rest of the weekend. It was a pleasure.
Yeah, and also thank you to all of my the GAPU IT team, especially Jitendra Malik, who is always there to support us with this program. And thank you, audience, for joining us today. And hope you are taking back some take-home lessons from today's webinar. So thank you, everyone. And then we will end the webinar now and hope to see you all again soon. I think we will have the next webinar again in 2 months' time. So this is June. So July, August, we'll be having another one. And I will keep you posted with the new topic. Thank you.
Thank you very much, and goodbye.
Bye-bye.
Bye.